Hello everyone, welcome to the third part of chapter inflammation. Here in this lecture we are going to discuss the various morphological patterns of inflammation, like how we have discussed what are the morphological patterns of necrosis. Then we will be discussing about the fate and outcomes of acute inflammation, systemic effects of acute inflammation. Then we will go to chronic inflammation. So these are the topics that we are going to discuss today. Last class I have told you that we have some vasoactive amines which mainly cause increased vascular permeability and vasodilation, and arachidonic acid metabolise helps in chemotaxis. We have lot of cytokines, TNF, interleukin 1, interleukin 6, and kinins mainly mediates pain. Let us see what are the morphological patterns of acute inflammation. Whenever you are going to read about this topic, two important points you have to remember. They are the hallmarks of the acute inflammatory reaction. They are the dilation of the small blood vessels and accumulation of leukocytes. First type is the serous inflammation. Serous. So the word serous means what? Exudation of cell poor fluid. There is no cells in the fluid, like peritoneum, pleura, or pericardium. That means we have the pleural fluid, peritoneal fluid, pericardial fluid. Am I right? Yes. So all these fluids, whenever there is an inflammation, we call it as serous inflammation. Fine. Remember, the serous inflammation, they do not contain any microbes or leukocyte. The best example, and why this inflammation occurs? Because of increased vascular permeability, there will be accumulation of fluid in the cavity. We call it as effusion. Am I right? Pericardial effusion, pleural effusion, all those. So you can see the histopathological picture where you can see this is the epidermis, this is the dermis. In between that you can see some spaces. Am I right? Or vacuolar spaces you can see here. And that is actually what we call it as the serous inflammation. It is fluid which is free of any cellular debris or microorganisms. Fine? Yes. The second is what we call it as the fibrinous inflammation. As a result of vascular permeability, the fibrinogen present will come out and it is deposited in the extracellular space. And this undergo further polymerization and it undergo deposition to form what we call it as fibrinous inflammation. Mainly seen in meninges, pericardium. Histologically, you can see a fibrin. Fibrin in histology, as you can see in this picture, see all these are fibrins. See, they are eosinophilic coagulum. You can see the eosinophilic plug. Okay, they looks like an eosinophilic plug. Very, very important point. They looks like an eosinophilic plug or an amorphous coagulum. The best example is fibrinous pericarditis. The pericardium which covers the heart will undergo this type of fibrin deposition, and this again we will discuss in the cardiovascular pathology. And this characteristic appearance we call it as bread and butter appearance. Bread and butter appearance because it looks like we have spread the butter over the bread. Okay, the bread refers to the pericardium here and the butter is nothing else but the fibrin deposition, and this characteristic appearance is called as bread and butter appearance. You can see histopathologically eosinophilic plug. Once that is over, we have two types. Another one is called as purulent. Okay, purulent or suppurative inflammation and abscess, and another one is ulcer. What do you mean by purulent? Purulent means suppuration. That means in serous inflammation, the fluid is free of microorganism. Here, the fluid is nothing else but the pus, which is nothing else but a debris of necrotic cells, edema fluid, and this is purulent. Why it is purulent? Because it is most commonly having an infectious etiology, like Staph aureus, okay, Staphylococcus, okay. And for example, acute appendicitis, it is an example of an acute suppurative inflammation. Suppose if this pus get collected at a particular area, so you can see here, this is the cut section of the lungs in case of bronchopneumonia. Okay, you can see there round, okay, you can see some yellowish collections of pus. Okay, so this is nothing else but called purulent or suppurative. Suppurative means pus. Okay, purulent means pus. That means it is as a result of an infectious etiology. Okay, yes. And in histopathology, you can see this. What is this? These are nothing else but neutrophilic infiltrate. Very, very important. You should know how to identify a neutrophil. These are neutrophilic infiltrate. Neutrophilic infiltrate. You can see here. Okay, you can see bluish deposits. These are nothing else but the neutrophilic infiltrates. Okay, yes. So that is nothing else but what we call it as the purulent or suppurative inflammation and the abscess formation. And we have something, the last variety we call it as the ulcer. The ulcer is nothing else but a defect in the epithelium. Okay, it's a defect in the epithelium lining of any mucosa in any part of the body. For example, the mucosa is mainly present in the mouth, stomach, genitourinary tract, in skin and subcutaneous tissue. Whenever there is condition like in case of diabetes or in case of peripheral vascular disease, anemia, there will be some alteration in this epithelium. Best example we can see, this is nothing else but a duodenal ulcer. You can see a perforation, an opening. These are the normal mucosa, and here you can see an opening. See, this is the normal mucosal lining, and here you can see a defect. Okay, this is the defect. So this is ulceration. So ulceration is nothing else but a defect in the normal integrity of the epithelium lining the mucosa of all the body cavities. Okay, yes. Fine, yes. So as a result of this ulceration, what will happen? Again you will see neutrophilic infiltrate. Okay, starting there will be neutrophilic infiltrate, followed by you will get plasma cell infiltrate. Okay, yes. So that is the point you have to remember in case of the best example. Example is very important. Acute appendicitis is an example of purulent. Okay, purulent or suppurative inflammation. Ulceration, best example, stomach or duodenal ulcer, you can say. Okay, and then rest all I have told. Fibrinous pericarditis, bread and butter appearance, and we have serous inflammation in case of what we call as pleural pericardial peritoneal effusion. Once this is over, what are the acute inflammation's outcome? Either it will undergo complete resolution, that means the tissue will become normal, or it undergo healing, as a result of which there will be scar formation or fibrosis, or this acute inflammation may progress to chronic inflammation. This is very, 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 very important. It's the VVIP 3 points. What are all of the following are the outcomes of acute inflammation except. So remember these points. Either it may completely undergo resolution, either it may progress to what we call it as the chronic inflammation, and either it may heal by what we call it as scarring or fibrous tissue. Then I am telling a summary. I have told you what are the cardinal signs of inflammation: rubor, calor, tumor, dolor, and functional Functional is the all other four are given by the scientist Celsus, and the functional was given by Rudolf Virchow. Rudolf Virchow is known as the father of pathology. So redness is rubor, warmth is calor, swelling is tumor. Okay, and you know why these are happening, because of the increased blood flow, edema, increased vascular permeability, all those things. Fine, and you can go through this picture also. Fine, nothing new in this. Fine, yes. Then coming into chronic inflammation. See, what are the causes of chronic inflammation? Yes, first you are going to tell what is the cause of chronic inflammation. The first important cause of chronic inflammation is as a sequelae. Okay, chronic inflammation may occur as a sequelae of acute inflammation. It may occur as a sequelae of acute inflammation. That is the first most common cause of chronic inflammation. Then, whenever there is any persistent infection means, for example, tuberculosis, mycobacterium, some viruses, parasites. Okay, and they actually mediate a type of hypersensitivity reaction. We call it as delayed type of hypersensitivity. I am not going to explain that now, because in immune system we will discuss that in detail. So, and this chronic inflammatory reaction will give a specific pattern. In acute inflammation we have studied serous, fibrinous, purulent or suppurative ulcers. Similarly, in chronic inflammation we have a morphological pattern that is called as granulomatous reaction. No worries, I will discuss that in a minute. Okay, yes. So the persistent infection, for example, Mycobacterium tuberculosis, it is highly resistant bacteria. So it can easily evade, it can easily protect it from our body's immune attack. So it is very difficult to eradicate. So our body takes a lot of time to eradicate this organism. So as a result, what will happen? The inflammation will progress over a very long period of time. That is why TB is one of the best typical example of a chronic disease. Fine? Yes. Or in case of some hypersensitivity reactions. Suppose we are allergic to some reactions, or we have some group of disorders. You will have learned what are they? Autoimmune disorders, myasthenia gravis. Am I right? Where the body itself will produce the antibodies against the body's own antigens. Am I right? Yes. So in such cases, in rheumatoid arthritis, multiple sclerosis, all these are autoimmune disorders. We have a long list. We will cover everything in chapter 6. And in all these conditions, what our body takes a lot of time to get rid of this disease. So that is again a cause of chronic inflammation. Then coming into what are the morphological features. Yes, what I have drawn within the box or the table is important. Infiltration with the mononuclear cells. There we have studied neutrophil. Here you are going to study what? Macrophages and lymphocytes and plasma cells. Tissue destruction. Whenever there is a persistent, there won't be that much tissue destruction. Okay. Yes, because it is an acute. Okay, it will become normal in few days or 1 or 2 weeks, but chronic inflammation persists for weeks, months and years. So persistent inflammation leads to tissue destruction. Then what? There will be also an attempt to heal, but healing leads to more scar formation, more fibrosis. Okay, don't worry, scar formation, wound healing, types of wound healing, everything is again another topic that we will see in the final part of the inflammation. So please remember, these are the 3 important points to say, or 3 hallmark features of chronic inflammation. See, you can see here, this is first. This is the picture A and B. You can see here, it's a chronic inflammation in the lung. Okay, yes, you can see here, you can see in this picture, here you can see what? Neutrophilic infiltrate. Am I right? Yes. And remember when you go to picture 2, okay, when you see the picture 2, what you can see here, okay, there are not only neutrophilic infiltrates, and at the same time you can see fibrin deposition. This red color, no, they are fibrin deposition, okay, over the walls of the alveoli, you can see here. Okay, and the neutrophilic, no, it is replaced by these group of cells. They are the macrophages. I hope it is clear. Yes. Okay. So once it's done, yes, how we have studied what are the mediators of acute inflammation. Again, the mediators and the cells of chronic inflammation can be asked. Okay, it is not asked till now, but it can be a potential short note question. Mediators of chronic inflammation. Fine. Yes. Here, the most important mediator is, okay, the cell which takes place is macrophages, followed by lymphocytes and plasma cells. What are macrophages? You know, from the bone marrow, hematopoietic stem cells, we have some circulating cells, we call it as monocytes. These monocytes get deposited in the tissue and get transformed to form macrophages. These macrophages in specific locations we call by specific name. For example, Kupffer cells. Okay, in liver, in spleen and lymph node, we call it as sinus histiocytes. In central nervous system, we call it as microglial cells. Lungs, we call it as alveolar macrophages. Okay, all this together, we call it as mononuclear phagocytic system. Earlier, this was called as RES, reticulocyte endothelial system. Remember, this terminology is no more used. Okay, yes, and there are long lists there. Okay, I will put it in some short videos and all. What are the mononuclear cells? What are the different names in different places? Okay, we will say that. Okay, so once that is done, we have to see what is the half-life of monocyte. Monocyte is nothing else but circulating in the blood. Its half-life is 1 day. Okay, it's an MCQ question. But what about the half-life of macrophages? It will be months or years. It is again an MCQ question. So I have told you alveolar macrophages, microglial, Kupffer cells, they are nothing else but the different names given to the macrophages in the different tissues in the body. Fine? Yes. And remember, when these macrophages get activated, they will produce some chemicals which is responsible for what? The tissue repair. And remember, as far as chronic inflammation is concerned, there will be more tissue repair. The chronic inflammation won't subside. What is the outcome of the chronic inflammation? The outcome of the chronic inflammation is what? Tissue repair, healing, scar formation, fibrosis. These are the outcomes of chronic inflammation. So, whatever the mediators secreted by the macrophages, they will cause fibrosis and what? Healing, wound healing. Okay, fine? Yes. So you can see here how the activated macrophages, fine, the resident Kupffer cells, all those stuffs you can see here, fine, okay. So once that is done, we have two pathways. Two major pathways of what? Macrophage activation. One is called as classically activated macrophage pathway. Another one is called alternatively activated macrophage pathway. Just focus on the picture. Fine? Yes. Classically activated macrophages. Okay, classically activated macrophages. See, each pathway has its own significance. Classically activated macrophage is mainly by some microbes or some infections. Okay, yes. Whereas alternatively activated macrophages, no, they mainly helps in fibrosis. And resolution of inflammation. So So classically activated macrophages, whenever there is a microbial product, it will what? Release something called as, or it will induce the production of something what we call as interferon gamma. This interferon gamma is responsible for classical activation of macrophages. Now the macrophage is activated, they release two set of compound. Number one is the reactive oxygen species and nitric oxide, which is responsible for microbicidal action, phagocytosis and killing. And another group is called interleukin 1, 12 and 23 that is responsible for inflammation. Whereas that is it is going to proceed, it is going to encourage inflammation. Whereas alternatively activated macrophages is activated by group of interleukin called as interleukin 13 and 4. You should not forget this interleukin 13 and interleukin 4. These are the two molecules which are responsible for alternate activation of macrophages, which is responsible to produce growth factors and TGF beta, or interleukin 10 and TGF beta. They are going to what? Stop the inflammation, that is anti-inflammatory effect, and they are also going to produce the tissue repair and fibrosis. So the question is very clear. Which of the following pathway has anti-inflammatory effect? In acute inflammation, I told you all are pro-inflammatory except lipoxins. Lipoxins are anti-inflammatory. Similarly, alternatively activated macrophages A4A alternatively anti-inflammatory effect. Okay, yes. And interleukin 13 and 4. Whereas interferon gamma means classical activation, that is microbicidal action, as well as it promotes inflammation. So this is what they have discussed here. The two pathways can be asked as a potential short-term question. See, interleukin 4 and 13, interferon gamma, and produce nitric oxide. Okay, I hope things are very clear for you. Are very clear for you. Yes. Okay. Then let us see which cells are going to produce. I told you interferon gamma is produced, interleukin 13, all those are produced. Let us see which cells are going to produce. What we call it as this interleukins and cytokines, which cells are going to produce. Before that, let us focus on this picture. See, we have this is actually a classical pathway. See, interferon gamma activated macrophages, and as a result of the classical activated action of macrophages, we have what we call it as granulomatous reaction. Here comes the question. Granulomatous reaction is as a result of classical activation of macrophages. Granuloma means it is a morphological pattern of chronic inflammation, like how we have studied serous fibrinous. Here we have the chronic inflammation, granulomatous inflammation. So this entire structure is called as the granuloma. Granuloma has activated macrophages. It has some fibroblast cells, okay, and some macrophages, and it has something called as an epithelioid cells. They are epithelium looking cells or epithelium like cells. We call it as epithelioid cells, and these epithelioid cells and activated macrophages, they fuse. Okay, activated macrophages and epithelioid cells, they fuse to form what we call it as giant cell. Why they are called as giant cell? Because they are multinucleated. Okay, from many macrophages, many epithelial cells, all these clump. So they have a common cytoplasm with many nucleus. We have different type of giant cells, that is Langham's giant cell, foreign body giant cell. Okay, all those things that we will discuss separately. Okay, fine. Okay. So as of now, remember, as a result of classical activation of macrophages, the activated macrophages all will start accumulating along with the fibroblast, lymphoblast, epithelioid cells, and finally some of the epithelial cells and activated macrophages, they clump together to form what we call it as the giant cell, which is multinucleated. They have a common cytoplasm, but they are multinucleated. So let us see what are the T helper 1 cells secrete interferon gamma, MCQ, I am writing Q here. T helper 2 cells secrete interleukin 4, 5 and 13, another an MCQ, and T helper 17 cells mainly secrete interleukin 17, and they are also responsible for recruiting neutrophils and monocytes into the reaction. So T helper 1 secrete interferon gamma, 2 secrete interleukin 4, 5 and 13, and 17 secrete interleukin 17, and the recruitment of macrophages and neutrophils. Okay, I hope this is clear. This is a very, very important table. You can get multiple MCQ. Okay, all three can be asked as an MCQ. Fine, yes. So you understand what is granuloma as a result. So classical activation means what are the things used to come into mind? Microbicidal action, promote inflammation, third granuloma formation. What about alternate activation pathway? Yes, anti-inflammatory effect, very good. And one more thing, what is it? Yes, tissue repair and fibrosis. What are they? Interleukin 10 and TGF beta. The most potent anti-inflammatory agent is TGF beta. TGF beta is the most potent anti-inflammatory mediator. Okay, TGF beta. And another one more important point, TGF beta is responsible for fibrosis, wound healing. When I teach wound healing, this is the only cytokine or the factor I will always repeatedly mention. Fibrosis, wound healing and the tissue repair. All these are a function of our TGF beta. Okay, fine. Then once it is done, let us see what are the other cells. We have eosinophils, IgE in case of parasitic infections, mast cells, okay, mainly in case of our allergic hypersensitivity reactions, all those. Fine, okay. So these are the other important cells. Now let us see what is granulomatous reaction. See, or granulomatous inflammation. Granulomatous inflammation, it is a morphological pattern of chronic inflammation characterized by collection of activated macrophages, T lymphocytes, which is sometimes associated with what? Necrosis. Fine. Here comes some set of questions. We have, listen carefully, macrophage. We have macrophage. Macrophage is activated by interferon gamma. Interferon gamma means what pathway? Classical pathway. Now this macrophage is called as activated macrophage. What is it? Activated macrophage. This activated macrophage will get more cytoplasm, abundant cytoplasm, and it undergoes some morphological change to form what we call it as epithelioid cells. What are they? Epithelioid cells. See, epithelioid cells. Why? Because they resemble epithelial cells. Fine? Yes. And these epithelioid cells, okay, and these epithelioid cells further fuse. They fuse to form multinucleate giant cell. Multinucleate giant cells. I hope things are very clear for you. Please remember this at any cost. There should not be any confusion. Okay, please remember this. There should not be any confusion. Please, okay, I'm writing in a table. I'm writing in a separate table. Okay, I'm putting in a box. See, we have macrophages, interferon gamma, classical activation, activated macrophage. Activated macrophage acquire more cytoplasm, undergo morphological change to form epithelium resembling cells, or that is called epithelioid cell, which fuse to form multinucleate giant cells. Fine? Yes. We have different types of granulomas. Number one is called as foreign body granuloma. That means these granulomas are formed as a result of some foreign body which produce some inflammation. For example, talc, intravenous drug abuse, all those cells. Fine? Yes. So here what will happen? There will be centrally one foreign body present. Around that granuloma will be formed. I hope things are clear for you. Yes. We have something called as immune granulomas. Why immune? As a result of some T cell mediated immune response. I told you that T helper 1 cells produce interferon gamma. So what all things, fine, which stimulate T helper 1 cells, which will produce interferon gamma, will produce some type of granuloma. We call it as immune granulomas. Fine? Yes. Now let us see the morphological pattern, how this granuloma looks under microscope. First of all, they will have a pink cytoplasm. You can appreciate well, it is a pink cytoplasm, eosinophilic. You can't appreciate any cell boundaries, that is the cell architecture, everything is completely distorted. And you can see lot of epithelioid cells. These dot cells are nothing else but the epithelioid cells. And somewhere here, you can see these epithelioid cells undergo aggregation. Am I right? Aggregation. That is what we call it as giant cells, which are multinucleated. And the multinucleated giant cells, which are characteristically having a horseshoe-shaped nucleus. So you can see here, horseshoe-shaped nucleus. This is what we call it as Langhans giant cells. Langhans giant cells. Langhans giant cells. These are called as Langhans giant cells. Fine? Yes. So, and surrounding this, you can see here, no, these are nothing else but collar of lymphocytes, fibroblast. So now I am going to write down what is the structure of a granuloma. Listen carefully. What is this? Horseshoe shaped, am I right? Multinucleated Langhans giant cell. Langhans giant cell means only horseshoe shaped nucleus. Okay, you have to use the word Langhans giant cell only when you can appreciate the horseshoe shaped multinucleated condition. This is surrounded by, you can see collar of fibroblast, and now what I am drawing is lymphocytes. I am going to label it now. Lymphocytes, fibroblast, Langhans giant cells. This is what we call it as granuloma. I am writing here granuloma. MCQ. All of the following are a part of granuloma except these three things. Whatever is there in the option, you can mark that as answer. These three are the constituents. These three are the constituents of a granuloma. This is the structure of granuloma. Langhans giant cells. What are Langhans giant cells? The epithelioid giant cells undergo fusion to form multinucleated structure. We call it as Langhans giant cells. When we call it as a Langhans giant cell, when the nucleus appears to be like a horseshoe shaped nucleus, then only we can say Langhans giant cell, because we have foreign body giant cells and lot other variants are there. Fine? Yes. So that is the structure of granuloma. And this classical Langhans giant cell granuloma is associated with a condition called as tuberculosis. Tuberculosis is a classical and a very super example for what type of, you remember in tuberculosis, what type of necrosis we will get? Caseous necrosis. So tuberculosis is a best example of a caseating granuloma. So if there is something called as caseating granuloma, there is something, of course, we call it as non-caseating granuloma. Okay, there is a condition called as sarcoidosis. Non-caseating granuloma. That is a condition called sarcoidosis. Okay, the cause of sarcoidosis is not known. Okay, it is associated with the hilar lymphadenopathy. Okay, there we will get non-caseating granuloma. Okay, you will study about sarcoidosis, we will study in immune system. At that time we will see. So non-caseating granuloma example is sarcoidosis, but caseating granuloma, typical pakka super example is tuberculosis. That is, we will get all the findings of Langhans giant cell with the fibroblast, lymphocytes. You can appreciate all the features under histopathology. So this is about yes. So granulomatous inflammation, it is a very, very important short note question. You can't miss this. Okay, you have to write what it is. Okay, how they are formed as a result of that interferon gamma activation. Foreign body granulomas, what are immune granulomas? You are going to explain what is morphology, and of course, then see grossly I told you, you can see the caseous necrosis and all those stuffs, and best example you see in case of tuberculosis. It is a best example of granulomatous disease. So whenever there is a granuloma, definitely you have to rule out first granulomatous, that is a tuberculosis. We have another lot of diseases which you can quote as an example. That is what we call it as, it's mentioned in your table. That is tuberculosis caused by Mycobacterium tuberculosis. You can see caseating granuloma. You can write all the feature. Leprosy. Leprosy is an example of non-caseating granuloma. I told you, sarcoidosis. Sarcoidosis is an example of non-caseous means what? You won't see that cheesy necrosis. You won't see that cheesy necrosis on gross appearance. Suppose I take a section of the lungs, gross section of the lungs. If I see, there won't be any cheesy material. There will be cheesy material in case of tuberculosis, but if I see in leprosy, there won't be. So that is the first example, and leprosy is also an example of non-caseating granuloma. We have lot of, the list is a very huge list. I will post it separately in a small video about granulomas, about the different types of giant cells, what are epithelioid cells, physiologically where you can see the epithelioid cells. All this I will post it in short videos. Non-caseating granuloma, the best examples are sarcoidosis and leprosy. Just focus on this table. Syphilis produce sometimes what we call it as gummatous, gummatous lesion, and remember, as far as syphilis is caused by Treponema pallidum, and here you can see plasma cells infiltrate. See, usually in chronic inflammation, macrophages, this the Langhans giant cells, granuloma, all these are made up of activated macrophages, whereas in gummatous granuloma, plasma cell infiltration. It is plasma cell granuloma. Which of the following is a plasma cell granuloma or gummatous granuloma? Answer is syphilitic granuloma. Then cat scratch disease. Cat scratch disease is caused by, it's a bacteria. It is causing that disease. That is cat scratch disease. It will get what we call the star shape. This shape of this granuloma will be star shaped. That is called a stellate granuloma. And sarcoidosis, again non-caseating granuloma, and we have an inflammatory bowel disease, Crohn's disease and the ulcerative colitis. Inflammatory bowel disease, we have two entities. Of course, there are a lot of things you have to by heart without understanding, because in corresponding chapters in the future only we will be able to study in detail about that. But as of now, you have no other way. You have to remember this. In inflammatory bowel disease, IBD we call it as, we have two entities. Number one is what we call it as Crohn's disease, and another one is what we call it as ulcerative colitis. At least some of you have studied in GK Paul or something other physiology textbook. Out of that, only in Crohn's disease granuloma is present. This is one of the most commonly asked MCQ in your INI-CET exam. Crohn's disease only have granuloma. Ulcerative colitis, the granuloma is absent. Which of the following is not an example of a granulomatous inflammation? You can go for ulcerative colitis. Non-caseating granuloma example, leprosy and sarcoidosis. You can see stellate granuloma is seen in what type of, we have different types of granuloma, we have donut, we have donut granuloma, donut granuloma, it will look like a donut like this, This is a donut granuloma. It is classically seen in case of Q fever. Q fever, you will get donut granuloma. Donut granuloma. Then star shape or stellate granuloma. In case of this is cat scratch disease. You will get stellate granuloma. Yes. And gummatous granuloma, plasma cell granuloma in case of syphilis. Okay, fine. Then I told you, out of inflammatory bowel disease, only in Crohn's disease we have granulomas. Fine, yes. Coming into what are the systemic effects. Systemic effects of inflammation is again, it's a short note question for you. Fever. Already I have told you what are the factors which causes fever. Interleukin 1, TNF, PGE2. Then acute phase proteins. I have already told you that. Leukocytosis. Fine. Neutrophilia, eosinophilia, lymphocytosis, all those stuffs. Fine. All these are the systemic effects of inflammation. Just it is very easy. Just go through these salient features. See, fever. Fever means there is an elevation of 1 to 4 degrees Celsius of the body temperature caused by pyrogens. Pyrogens are the substance which induce fever. They may be either exogenous pyrogens like bacterial products and endogenous pyrogens which are interleukin 1 and TNF present within the body. That is why we call it as endogenous pyrogens. And all these will stimulate what we call it as PGE2. Okay, this is very important. Which prostaglandin is pyrogenic? Okay, this is an MCQ. Which prostaglandin is pyrogenic? Answer is PGE2. Fine, yes. Then we have acute phase reactants which are mainly produced from the liver, C-reactive protein, fibrinogen, okay, serum amyloid A protein. Okay, already you have studied. There will be elevation of ESR. Okay, there will be elevation of ESR. That is why ESR is elevated in case of inflammatory condition. Then hepcidin. Okay, thrombopoietin, leukocytosis, all those. These are the various systemic effects of inflammation. Okay, what are the 3 systemic effects? Number 1 is fever, number 2 is acute phase production, and number 3 is leukocytosis, and number 4 is what we call it as septic shock. Septic shock. That means, what is that septic shock means? There will be disseminated intravascular, all this because of the severe bacterial infections and all this, there will be disseminated intravascular coagulation. As of now, just remember as DIC. In chapter shock hemodynamics, we will discuss this in detail. And another by hypotension and metabolic disturbances like hyperglycemia, everything. The patient may go for what? Shock. Shock means shock may be due to many reasons. Hypovolemic shock, I think you would have studied in physiology. Hypovolemic shock, anaphylactic shock, septic shock. So here this is septic shock, most commonly due to an infection, severe bacterial infection. The patient may go for coagulation. Okay, or the blood undergo coagulation. It will go and occlude all the major organs like brain, heart, and everything. It will go and causes hypotension. It will causes metabolic electrolyte disturbance, and finally the condition is called as septic shock. So these are the various systemic effects of inflammation. So now I want to stress you something. I will be making some new or a separate video for number 1 granuloma, number 2 for epithelioid cells and different morphological patterns of joint cells, and number 3 for all high yield points. Okay, of course there is one more video left in inflammation, that is the wound healing and tissue repair, that I will soon be uploaded in a day. Okay, so these are some of the important points you have to remember. Fine, yes, and you should know what are the outcomes of acute inflammation, what are the patterns, and please read about granulomatous inflammation in detail. 2 pathways of macrophage activation. You should know how to draw the structure of granuloma. Okay, they may be asked. Okay, they may ask. You can draw this picture and explain in a short note question. Okay, I have mentioned everything in detail. What is Langerhans giant cell? It is a special type of giant cell seen in case of tuberculosis. Classical example. Don't write Langerhans giant cell is seen in all types of granuloma. No, Langerhans giant cell, we use the word only when the nucleus is horseshoe shaped, and that is classically seen in tuberculosis. So I hope you are okay with this. So hope this session is useful for you. Thank you.